Well, welcome to a mixed bag session, something changing the pace a little bit from those great talks. We're going to lead off with the director of the National Eye Institute, Michael Chiang, talking about what retina specialists should know about the NEI in 2024.
Paul, thank you very much. And it's really a privilege to give this talk on behalf of 800 people at the National Eye Institute. So we were established in 1968 as the branch of the NIH to manage national efforts in vision science. Okay, what we do is we direct and we fund vision research around the country. Our budget is $896 million this year. And I can only talk about a small number of things. I actually thought I had 7 minutes, and it looks like I only have 6 minutes. And so I'll abbreviate. Consider following us on social media. The Twitter handle is NEI Director and LinkedIn Chiang MF. Okay, so I just want to talk about two things that are going to be of interest to the Retina group. Number one is imaging and AI. There has been a ton of innovation. On the left side, Eric Topol tweeted in 2019 that there's more innovation in ophthalmology than any other area in medicine. But on the right, you'll see that the number of AI devices that have been funded, that have been FDA approved, this is all the different specialties, and radiology is number one, we're number 6. Okay, so how do we get more of this technological innovation into real world practice? One of the things that we've been doing is trying to, at the NEI, stimulate building larger data sets. Okay, there's a project called Bridge to AI, through the NIH Common Fund, huge project, $130 million over 4 years to build large data sets. And I'm really excited that one of the 4 groups that was funded through this $130 million is led by Aaron Lee and Cecilia Lee in Seattle for diabetes. Okay, so really huge win for the community. They're building large data sets of diabetic patients. If you're interested, some of this is available already publicly. So go to this website, talk to Aaron and Cecilia. We've gotten really interested in oculomics and trying to stimulate work in that area. Okay, what's oculomics? Retinal images, people building AI models to diagnose and predict systemic disease. Okay, Alzheimer's, Parkinson's, cardiac disease, psychiatric disease, really, really exciting. And so this is a new program that we created, $14 million over 3 years, to build devices coupled with AI algorithms to diagnose systemic disease. And a few weeks ago, we announced 3 different winners of that. And one group is led by Amani Fauzi at Northwestern. One is led at NYU to look at Alzheimer's and Parkinson's biomarkers. And Amani is looking at systemic vascular health monitoring, based on imaging. And Jianhua Wang at Bascom is developing methods to develop novel imaging techniques to look at retinal capillaries and measure blood flow with the premise that this will get a window into dementia and small vessel disease in the brain. Okay, so a lot of innovation in the oculomics space. Number 2 topic is clinical data interoperability. Okay, 21st century work and clinical care is all about sharing data and collaborations. The problem is that different EHRs are like apples and oranges. And even 2 epics don't naturally share with each other, and so that makes it really tough to collaborate. Okay, so what are we doing? We're working with the AAO to build a common data model for ophthalmology. Okay, that doesn't exist yet, and what does that get us? You get all these different apples and oranges, it converts them to a common data ecosystem, and then we can then create standard cohorts and do a federated data analysis. And I'll give some examples of that, but what I would love is for the vision community to be able to do this in a standardized way. That would be really, really powerful. Okay, and just in terms of sharing data, there's 2 ways that we can do this. One is to centralize the data. Okay, everybody sends their data around the country to a single repository. Okay, that's Iris Registry. There's a source consortium at the University of Michigan. And the benefits of this are that you get access at a single point. Okay, that it's really simple and intuitive. The con is that it requires really extensive data use agreements to send data from site to site, and that can take years to forever to set up. And the other thing is that these are really big files, okay, imaging files, and so not always practical. There's a new approach, federated data networks, where the way that this works is that the data stay locally at each site, and the analysis is done in parallel, and you share the analysis. Okay, and there's been some really neat proof of concept networks around the world that use this methodology, and we've become really excited by it. Okay, the benefit here is that you don't need data use agreements because the data stays locally. Okay, but the con, of course, is that because you analyze in parallel, you need to really, really harmonize your data and to make sure you're comparing apples and apples. And so does this actually work? Cindy Kai, a retina specialist at Hopkins, did a really neat pilot study where she asked a simple question. For people who are getting anti-VEGF injections, what is the risk of kidney failure? And does it depend on what drug you use? And so by using this common data model federated analysis method, she looked at 12 data sets around the world, converted all to this common data model, and in 9 weeks was able to look at 485 million patients and build a large cohort of patients who met these inclusion criteria and do that study. Okay, no data left any of those 12 sites, and really, really exciting. And so based on things like that, we've created a $1 million NEI challenge where people can propose questions that could be answered using a federated approach like this. And if you're interested, go to this QR code. It'll give you information about that challenge. Okay, so with that, this is my last slide. I'm really excited to work with everybody here to make those scientific advances that are going to help us take better care of patients. Here's the social media handles. And this QR code takes you to a site that lists all the different NEI grant opportunities. Thank you very much.
Thank you, Michael. Our next speaker is Paul Hahn, who's going to speak on a topic of great interest to me, cost effectiveness of step therapy and inflationary changes in reimbursement. Paul.
All right. Thank you, Paul, and thank you to the program committee for giving me the opportunity to talk about something a little bit less conventional. Rather than talking about the latest and greatest, we're going to focus on threats to our practice of medicine. Shown here are my disclosures. And I want to point out that this work was performed under the ASRS Health Economics Committee. I had the privilege of being chair to a fantastic group of individuals, and the Health Economics Committee is tasked to provide data-driven analyses to support larger ASRS advocacy efforts. Over the next few minutes, we're going to talk about two topics. The first is step therapy, which of course are insurance-mandated protocols for treatment which require initiation of therapy with a less expensive drug first. In the case of retinal diseases, typically off-label bevacizumab. Step therapy overrides any of our physician expertise, judgment, and choice, for example, based on available data showing us that for some patients with DME, bevacizumab is an inferior option. The DRCR should be credited for designing a clinical trial to better study step therapy. They looked at aflibercept 2 milligram monotherapy versus bevacizumab first with a switch to aflibercept as needed, and identified equivalent outcomes at the 2-year time point. Bevacizumab first was cheaper and identified to be cost-effective, which of course was not very helpful for our advocacy efforts. But there are a few things to point out with Protocol AC. Slower vision and anatomy gains were seen with bevacizumab first, and the difference in the area under the curve identifies that lost vision and anatomy. 70% in the bevacizumab arm required a switch to aflibercept by year 2, and with such a high switch rate, perhaps it's not surprising that the 2-year outcomes were equivalent. And these results were seen in a clinical trial setting with a high treatment burden that far exceeds what we can expect to perform in the real-world setting. So we thought the more interesting comparison would be to compare bevacizumab first to the real world. Dilraj Grewal and the committee spearheaded this project looking at the Vestrum Health database, and he identified a study population in the real world with characteristics similar to Protocol AC. He chose a study year of 2016 to 2018 to follow best available data from Protocol T, but to predate many of the step therapy mandates, which have more recently become so universal. And of course, he found that in the real world, we do far fewer injections and visits compared to clinical trials. Of course, we also see lower vision outcomes, but he identified a subcohort that was vision matched to the same 14 letters seen in Protocol AC and still identified fewer injections and visits. So he quantified the direct medical costs of the injection, imaging, the exam, and of course the drug, and identified 41% lower cost in the real world compared to Protocol AC, and even if he matched to 14-letter vision, still 20% lower cost. Therefore, demonstrating that real-world costs based on physician judgment are lower than Protocol AC, even if we match vision outcomes. Ella Leung within the committee decided to take this a step further, and rather than looking at only direct medical costs, focused on total societal costs. And by comparing total societal costs between Protocol AC bevacizumab first and the real world, and normalizing this to the difference in vision, or actually quality-adjusted life years, she can estimate cost effectiveness over 2 years and the modeled lifetime of 17 years, and identifies a 20 to 40% difference with protocol AC being more expensive compared to the real world, with incremental cost-utility ratios that far exceed most societal willingness to pay thresholds, indicating that protocol AC bevacizumab first is less cost-effective than the real world. Indeed, if all patients estimated to have DME in the United States are converted from their real-world regimen to protocol AC bevacizumab first, it might cost $52 billion over the modeled lifetime. This result is obvious to us as clinicians. We know that protocol AC is a clinical trial and does not simulate real-world practices, but it is not obvious to policymakers, and it's important for us to provide data to demonstrate the value of physician judgment and expertise in the real world over simply mandated protocols. I'm going to switch gears and talk about inflation now, a topic which has, of course, affected everybody in every aspect of life. But we're going to focus on change in time over a 10-year window for the 10 most common retina services with respect to reimbursements. So Dan Gong and Phil Niles in the committee looked at Medicare Part B data for the 10-year window from 2015 to 2024 and looked at changes in reimbursements, both non-adjusted as well as inflation-adjusted changes. Not surprising to anyone who follows reimbursements, our non-adjusted payments have been relatively flat over a 10-year window, which means that if we adjust for inflation, we've actually seen a 25% decline. Medicare pays us by RVUs, and RVUs actually have 3 components. The first is the physician work component, representing our time, labor, skill, and intensity and effort. The second are practice expenses, rent or leasing your office, supplies, equipment, and staff labor. And the third is the cost of malpractice insurance. We were particularly interested in the practice expense component because this is, of course, very directly sensitive to inflationary changes. And not surprising, all 3 components demonstrate a similar trend: flat reimbursements, flat unadjusted reimbursements over a 10-year window, and if we adjust for inflation, we see a 20 to 30% decline. This applies even to the practice expense component, which is, of course, directly sensitive to inflation. Now, this is outrageous, but it actually applies to all fields of medicine, at least for physicians. The kicker is that this reimbursement decline is specific to physician payment. If we look at all other fields or all other aspects of medical reimbursement, skilled nursing facility, outpatient hospital, inpatient hospital, we'll see that these go up at a rate that is equal to or exceeding most inflationary indices, just not physicians. The reasons for this are nuanced and outside the scope of this discussion, but I want to end with a very simple call to action. The first is that we should be offended. We should be offended that insurance companies are overriding our years of training and expertise in the absence of any meaningful data. We should be offended like your staff member would be if you told them you would not adjust their salary for decades. With that offense, involve yourself. If you can be politically active, fantastic. But for most of us, support your local organizations. The ASRS, Academy, the AMA, et cetera, have multi-pronged initiatives, and it's very important for us to show physician solidarity in those efforts. And finally, continue to practice the best medicine. That's the best ammunition we have during our advocacy efforts. And with that, I'm confident that ultimately our efforts to get collectively will be appropriately recognized. So thank you for your attention.
Thank you, Paul. Next, Rahul Khurana is going to talk about the effect of coronavirus and the COVID vaccine on retinal disease.
Thank you, Paul, and thank you to the organizing committee to give me the chance to speak today. Here are my financial disclosures. None of them are relevant to this talk. I want to start with a 26-year-old healthy gentleman who presented with a classic signs of a central retinal vein occlusion. Now, if this patient had told us that he'd been at a Chicago Bears game a few weeks earlier and did this cause this, I think we would all agree that maybe being a fan of the Chicago Bears may be deleterious to your mental health. Association is not causation. But what if this patient told you that he lost his sense of smell a few weeks earlier and was diagnosed with COVID-19? Would that change your diagnosis? Now, this was a patient that actually presented to our practice in the early parts of the pandemic. And unlike being a Chicago Bears fan, we know that COVID-19 can cause vascular damage and thrombus formation by activating the fibrinolytic pathway, setting off a cytokine storm, and causing embolus formation. And we've seen higher cases of deep vein thromboses, pulmonary embolism, myocardial injury, and strokes. And so when we look at retinal findings after COVID vaccine, there was a recent literature review that showed really a 9-fold higher rate of microvascular changes, including retinal hemorrhages, cotton wool spots, microaneurysms. OCT and angiography has shown changes in vessel diameter, and there have been case reports of acute macular neuroretinopathy, paracentral acute middle maculopathy, and there have been case reports of vascular occlusions, central and retinal branch artery occlusions, and central and branch retinal venous occlusions. But we want to move beyond temporality. Does the cause precede the effect? And there's a Bradfield-Hill criteria, which use 9 criteria to determine the strength of a causation. So let's go back to COVID-19 and vascular occlusions. We have case reports, and we have very compelling case series involving young patients like the patient I presented in the beginning with no past medical history. There was a large retrospective cohort study from the Kaiser Permanente group that looked at over 400,000 patients and found that within 6 months of a positive COVID-19 test, there was a higher rate of retinal venous occlusion, but not of retinal artery occlusion. But even in this study, the number of cases was quite small, about 60 cases. And the challenge with COVID-19 is how do you prove causation when the incidence is so high? As of August of this year, there have been over 776 million confirmed cases of COVID-19. And I think the answer here will lie with big data, and more specifically, with clinical registries. And the first one was our own American Academy's IRIS registry, which is the largest subspecialty registry in the United States that involves over 80 million patients. And so if COVID-19 did indeed cause retinal vascular occlusions, there should have been a higher number of occlusions there. So under the great work of Charles Lee and Flora alum, we determined the actual number of retinal vascular occlusions in 2017, 2018, 2019, and then determined a model of how many we should have expected to see in the pandemic in 2020, 2021, and 2022. So what did we find? In summary, we found out that retinal vascular occlusions did not increase during the pandemic. When we looked at branch retinal vein occlusions, central retinal vein occlusions, branch retinal artery occlusions, and central retinal artery occlusions. When we look at that patient that I presented in the beginning of the talk, we can see by the purple line there was actually a decrease in the number of CRVOs, and it never increased than what we would have expected. And we are aware that during the COVID-19 pandemic, there was a suppression of ophthalmic care utilization, with more severe diagnoses making a larger percentage of our clinic visits than less severe ones. So even though the number of vascular occlusions did not increase, they made up a higher percentage of our clinic visits, giving us the impression that there was a higher incidence. And this was also consistent with another publication by Dr. Darius Moshegi, which looked at the Vestrum database with American US retina specialists. Although both analyses are compelling, they still have limitations. They didn't have COVID-19 testing in these databases. And so really, the definitive paper really came out from our colleagues in South Korea. And this was a nationwide population study looking at over 8.5 million patients. And what they found was that there was no increase in retinal artery occlusions nor retinal vein occlusions within 60 days of a positive COVID-19 test. So we're going to change topics to another controversial area, COVID-19 vaccinations. And there are indeed serious side effects that have been reported: myocarditis, vaccine-induced immune thrombotic thrombocytopenia, and venous thrombosis. And when we look at after case reports in our retinal literature, there have been case reports involving macular edema, retinal vasculitis, retinal venous occlusion, retinal artery occlusion, and cotton wool spots. But the challenge is, with so many vaccines, how do we prove this? And no, Dr. Evil, 1 million vaccines have not been given, but rather 13.7 billion vaccines. And with so many vaccines, it's very hard to prove causation. There have been some good research that's helped us, may give us some more reassurances. The COVID-19 research network within the TriNet X analytics platform is a federated network that Michael talked about us earlier, but involves over de-identified health medical records, over 100 million patients from 77 healthcare organizations across 9 countries. Dr. Singh and company and his group looked at over 3 million vaccines, and within 3 weeks, they found extremely low rates of RVO, 0.003% after the first dose vaccination. They also looked at other patients who were propensity matched after getting influenza or Tdap and saw similar rates. The second piece of evidence, again, came from our colleagues in Korea, from Dr. Lee and Dr. Kim. And they showed in that same paper, involving a nationwide population study of over 8.5 million patients, there was no increase in RAOs and RVOs after COVID-19 vaccination. Now, there was a possible small increase in women with the mRNA vaccination, but that N was still quite small. And finally, our third piece of evidence involves the CDC's Vaccine Adverse Events Reporting Systems. This is a global reporting system looking for adverse events after vaccination. Now, this does involve passive surveillance, so there could be underreporting, but Dr. Agarwal's group looked at over 2 billion vaccines administered and found about 1,300 RVOs reported globally, with very low crude rates showing a low safety concern after RVO after vaccination. So in summary, we have multiple cases and series of retinal disease after COVID-19 and COVID-19 vaccination. Causality is extremely challenging when the incidence is so high for both things. And causality so far has not been proven in large databases. Thank you for your time.
Thank you, Rahul. Final talk in this session is from Dr. John Thompson, who's going to share his thoughts on the usefulness of the IRIS registry for retina use.
Great. Thank you, Sophie and Barb, for giving me the opportunity to speak. My financial disclosures are not relevant to this presentation. Many of you are familiar with the IRIS Register, which captures clinical data from several dozen electronic health records used commonly by our colleagues. It's celebrating its 10-year anniversary now. It was created with two main goals. Number one, to allow ophthalmologists to participate in the quality programs created by Medicare, and to create a large ophthalmology registry to facilitate research studies from a diverse group of ophthalmologists. Well, the Medicare MIPS program, let me digress a little bit. This is meant to encourage quality medical care by giving financial bonuses or penalties, depending upon which side you fall. Then the original MIPS measures were process measures, fairly easy, like examining the retina in patients with diabetic retinopathy or recommending the ARED supplements. But now Medicare is focusing on outcome measures like loss of less 3 lines in patients with DME or visual acuity improvement after diabetic vitrectomy. The problem with MIPS is that now the bonuses, there's no exceptional bonuses, so if you get 100, you might get a 2% bonus, but it penalizes you up to 9% if you don't meet that 75% threshold. Well, it's really very difficult to measure quality in diverse patient populations with different diseases. It also requires substantial time and money to participate and avoid penalties. This looks at MIPS penalties across all physicians from AMA data. If you happen to be a solo practitioner, it's estimated 46% of you are getting penalties. If you're in a safety net solo practitioner, it's up to 52%. Peer-reviewed literature shows no quality improvement by physicians or hospitals participating in these programs. And the worst part of it is that MIPS discourages physicians from taking care of minority and socially disadvantaged patients. It's well established that these groups have less favorable outcomes for a variety of retina treatments due to complex social and economic factors. So basically, it rewards physicians who practice in Beverly Hills, and it punishes those who practice in East Baltimore. The good news for ophthalmologists who use the IRIS registry is that no ophthalmologist who has participated has received penalties from Medicare. They work very hard to prevent that. Well, IRIS by the numbers. 12,000 ophthalmologists participate. It's a free member benefit from AAO, 80 million unique patients, 670 patient visits now. The AAO owns IRIS and a small portion of Khurana. It's funded by selling anonymized data in industry. The data is safeguarded and meets all federal or exceeds federal standards. The registry was initially managed by F MD, but moved about 2.5 years ago to Khurana, and the accuracy of data mapping has improved substantially. Our practice found frequent errors receiving credit for quality measures with F MD, but very few errors now with Khurana. But you still must check your dashboard during the year to make sure your EHR data is getting mapped appropriately. So what is the value of the IRIS registry? Well, it allows us to avoid these penalties in MIPS, but it's been a huge asset for ophthalmology research, and I think this is its real value. There are over 133 published articles derived with data numbers in the tens or hundreds of thousands. The IRIS registry is also much more complete than these claims-based healthcare studies, since virtually all of the EHR data is ingested except for imaging. It will allow some very interesting longitudinal studies to be performed as treatment patterns are evaluated and outcomes over 10 to 30 years in the future. And the use of artificial intelligence to evaluate this huge data set will facilitate even more detailed analyses of diseases and outcomes. But what are the limitations? These big data studies are not perfect. All registries are dependent on accurate clinical data, and unfortunately, our EHRs contain many errors. Data entry errors. When we had dictated or handwritten notes, we had many fewer errors than our EHR. Cloned exams carried forward lacking updated data. Failure to code more specifically with ICD-10 codes. Patients lost to follow-up. Their outcomes are not adequately captured. They may not return because of a bad outcome, or they may not return because they're doing well and they don't see a need to return for an examination. Patients who are lost from the IRIS registry when they get care at a center that does not participate with the IRIS registry. And currently, 30 academic centers participate, but many still don't. Insignificant statistical significance. Studies of tens of thousands of patients can reach very high levels of statistical significance with a minuscule clinical difference, and it may not be important in terms of a visual acuity difference of 1 or 2 letters. Confounding. If the baseline characteristics are not the same, one group may have different outcomes. A more severe disease may be treated with a different procedure, making this procedure appear to have worse outcomes. So it's important not to confuse correlation with causation. Appropriate interpretation of results. You need to consider limitations in the data. And the limitations in IRIS is it doesn't have imaging studies currently. Most ambulatory surgery centers don't participate, so we don't have that. Also, incomplete information on race, ethnicity, and social determinants of health, and data not available from many academic medical centers. None of the people shown in this presentation are real. All of these were generated by artificial intelligence using verbal descriptions that I put in. Even the 2 mice are AI generated. So in conclusion, the IRIS registry has become a valuable resource for our AAO members. It's helped us to avoid penalties and receive some bonuses in the past. But the most valuable aspect of the IRIS registry has been to promote clinical research to answer questions that would not have been possible with smaller data sets. And I would like to thank Catherine Rupp, who helped me understand the statistics of big data and their limitations, as well as Flora Lum, who helped me understand the IRIS registry better. Thank you very much.
Thank you, John. This concludes this session of the subspecialty day. I'm now going to turn over the platform to our CEO, Dr. Stephen McLeod, who will introduce one of our heroes, Steve Charles.